Thanks for that kind introduction, Corey, and thanks for the invitation to present today. This is a great meeting, and I wish I could have attended more of it. I think I looked at the lineup from yesterday, and it was really a star-studded cast, and lots that I probably could have learned from that. So the questions have kind of set the stage for what we're going to talk about now, and really focusing on EGFR inhibitors. The first talk is entitled Beyond Erlotinib, Better EGFR Inhibitors. And we'll go through this, and then the next talk is really more focused on how I manage acquired resistance in the setting that we are today. Less about future and possible things, and more about real life. What do we do today? So when I think about going beyond erlotinib, I think, well, what would an optimal EGFR tyrosine kinase inhibitor be? What would it do? Clearly, it would have to have efficacy in EGFR mutant cancers. It'd have to be better than chemotherapy. It'd have to have the fewest associated adverse events. So we know of a handful of side effects that these medicines cause, and we'd want to have the least of those. We'd ideally like a drug that actually targets mechanisms of erlotinib acquired resistance, or at least first generation acquired resistance, so that we could actually help those patients. And beyond targeting it, it actually has to have clinical activity. It has to be effective against clinical acquired resistance. And so that's something that I think this is the layout of what I would think of as an optimal thing. And so I've got a little scorecard here that we're going to go through and talk about erlotinib and afatinib and see if afatinib adds to erlotinib. And then at the end, I'll talk a little bit about the horizon for newer EGFR inhibitors. All right, so does erlotinib work against EGFR mutant lung cancer? Yes. So this is the waterfall plot from Raphael Rosel's trial. It's a trial done in Europe, enrolling only patients with EGFR exon 19 deletions and EGFR LA58Rs. And you've seen waterfall plots like these many a time. Each bar represents an individual patient and their best response to therapy. And you see that the vast majority of patients have significant tumor shrinkage, most with a partial response. Clearly, unfortunately, there are a handful of patients over here in the top left that frustratingly don't respond to therapy. We don't know too much about those, and I think it's an important group of people to study because the promise of targeted therapy is not something that works for them. So this meets one of the key definitions, and then of course it's better than chemotherapy. This is again from the European trial. The trial randomized patients to either erlotinib or to standard chemotherapy, whatever the docs usually use in that setting. I believe it was a carboplatin paclitaxel or gemcitabine carboplatin, or cisplatin could also be incorporated there too. But nonetheless, standard chemotherapies that we would all generally use, they didn't use pemetrexed because it was Europe, so it's not, maybe they're not the best comparison. But again, erlotinib is much better than chemotherapy, has a ratio of 0.37, not too many lung cancer trials prior to the EGFR TKI era where we had hazard ratios of 0.37. It's really a shockingly good ratio. All right, so this meets the first two definitions. Is it effective and better? So now how about afatinib? So this is, I should mention that afatinib is a newer, irreversible EGFR tyrosine kinase inhibitor. It hits EGFR as well as some other kinases, including HER2, and the activity against HER2 may be of relevance targeting HER2 mutant lung cancer, and there actually may be some role in that HER2 activity in treating EGFR mutant cancer, but I'm not going to focus on that right now. So first it has to meet the bar. Is it effective in EGFR mutant cancers? And this is a data that was recently published. This is a single-arm study giving afatinib to patients with EGFR mutant disease. And what you see here is that it does, in fact, shrink a lot of cancers. The vast majority of patients with EGFR exon 19 deletions or LA58Rs have tumor shrinkage. Most have partial responses, so meets that bar. I'll just, as a sidelight, tell you that I had 2 patients on this trial, and one patient lasted three and a half years on afatinib. So it was really a good drug for her. So is afatinib better than chemotherapy? Yes. This is a trial that was presented at ASCO in 2012 and recently published. This is the comparison of treatment of afatinib to cisplatin pemetrexed. All these patients had EGFR mutations, and you see that clearly afatinib is better in terms of progression-free survival than cisplatin pemetrexed. I think much is made of the fact that this is what many would consider a state-of-the-art comparator, that cisplatin pemetrexed is probably the best chemotherapy one can imagine in this situation, though that's certainly arguable. But this is certainly a state-of-the-art regimen. And again, an excellent hazard ratio of 0.58, showing that afatinib is much better. So this afatinib now meets these two criteria, better than chemotherapy and effective. So now let's start looking at side effects. And this is dangerous. I'm going to cross-trial comparisons. This is always a concerning thing, and I think looking at trials for effectiveness across trials is challenging, and it's a little bit fraught. But then the thing I'm going to do that's even worse is I'm going to look at the toxicity profiles comparing across trials, which is especially dangerous because everybody grades things in a very different way, and it really depends a lot on where those trials are done. So let's look briefly at effectiveness. These are the two biggest trials, the Russell trial for erlotinib and the afatinib trial the Sequest trial for afatinib. Relatively decent-sized trials, 100 to 200 patients. Response rates virtually the same, 58% and 56%. Median progression-free survivals very similar, 10 months and 11 months. And overall survival for erlotinib, 19 months, and for afatinib, not reached. So it's hard to compare those two. But I think what I would say from this is that there doesn't seem to be a resounding efficacy difference between these two drugs, though certainly one can argue that comparator arms are different and all this sort of stuff, but I think there's a fair amount of evidence they're about the same. So now let's look at toxicity. Same two trials, and looking at things that you and I care about when we're seeing patients. Grade 3 events, rash, grade 3 diarrhea, and then grade 3 paronychia is another one that's come up more recently. So grade 3 rash is pretty similar, 3% or 13% and 16% in these two big studies. And I think I've treated a fair amount of patients with both those drugs, and I would tend to agree that the rash is fairly similar. The rankings of grade 3 diarrhea are a little different. So in the Russell trial it was listed as 5%, and in the Sequest trial it was 14%. Another trial is recently reported out in which the afatinib rate of grade 3 diarrhea was also 5%. So it's probably a bit of a wash, though I have a sense that there might be a bit more in terms of side effect, in terms of diarrhea for afatinib. And then I have to admit, paronychia is something that we've always seen in patients treated with EGFR tyrosine kinase inhibitors. All these nail changes that we get used to managing as oncologists, but for the patient who experiences it, it's kind of a burdensome thing. And we've definitely seen that with erlotinib, but unfortunately it hasn't been widely captured in the data for most erlotinib trials, and so it hasn't been reported. In the afatinib trial, grade 3 paronychia was listed as 11%, and I think that's about right. It is something that we have to specifically learn to manage, because it's a little different than, say, the nail changes we see with docetaxel. It's quite painful for some folks. But I think comparing these two things, maybe erlotinib has fewer side effects, maybe afatinib does. There's no real win there. So now let's think about targeting mechanisms of acquired resistance. This slide shows in the bottom half, there's a pie chart showing what the mechanism of acquired resistance is. I'll talk a little bit more about this in the next section, but when we're targeting, when we have a patient with EGFR mutant lung cancer and they develop resistance, our first question is why. We want to understand why. And one of the main reasons we want to know why is because it's a little hard to make out in this pie. I apologize for that. But if you look over on the left side, there's 3 categories that have small cell lung cancer. So about 4% of patients with EGFR mutant cancer who are treated with erlotinib or gefitinib and develop progressive disease. If you rebiopsy those folks, you find small cell lung cancer. Some reports are much higher. I think this is probably a more accurate number, about 3-4%. It's not a common entity, but certainly something that if you see it, you'd like to know, and you'd like to try some small cell type chemotherapy. acknowledging that that's a strange area without data, but I think it's rational to consider that approach. But by far the most common mechanism of acquired resistance is EGFR T790M. So T790M is a second mutation in EGFR. It's almost never found in baseline specimens. Maybe 1% of EGFR mutant cancer has a T790M at baseline. And this T790M occurs in about 60% of patients with acquired resistance. In vitro, in the cell culture and in mouse models, if you put that mutation in, those tumors never respond to erlotinib or gefitinib, and so it's a key target as we go forward. So one of the big promises of afatinib is that it potentially has activity against T790M, and this is a in vitro kinase diagram. I'm sure this is the sort of thing you guys look at in clinic every day, or maybe you don't. But BIBW2992 is afatinib, and this lists the activities, and what you want to have is a relatively low number here. This is the low concentration at which it inhibits the enzyme, and you see that afatinib, as compared to gefitinib, is actually more effective against EGFR wild type, more effective against L858R, and several log orders better, or 2 log orders better for L858R with T790M. So this really got us excited, and then also, as I mentioned earlier, HER2, it seems to target HER2 as well. So this is one of the backbone reasons why afatinib moved forward, is because of this excitement. Similarly, that was in vitro kinase data. This is actually cell lines, and I'd point to the fourth column, NCI 1975. 1975 is a cell line that has that T790M in it, L858R and T790M, so it's a model of acquired resistance. And again, here, lower numbers are better, and you see that for BIBW2992 or afatinib, there's a relatively low number of 99 as compared to gefitinib and erlotinib, which have numbers of greater than 4,000, suggesting that you could actually target 1975 cells, these acquired resistance cells, with afatinib. It's a much lower number. It's way better than gefitinib or afatinib, but the concerning thing is that that's kind of a high number to get to in people. So it may not be a targetable thing. And then just to highlight in the far right column that afatinib is irreversible as compared to both gefitinib and erlotinib, which were reversible. And that provides theoretical benefits. You and I will have to judge the data to tell us whether that's an actual benefit. All right, so we can put that firmly in the column that afatinib targets mechanisms of acquired resistance. So that's cute, and cell lines and in vitro kinase profiles are nice, but what about actual clinical activity in this setting? So, sorry, I thought I had a schema here. To evaluate that question of whether afatinib is effective in clinical acquired resistance to erlotinib, this trial was done. If you're into the lingo, this is the Lux-Lung-1. This is a trial that was begun a number of years ago, because this was really thought to be the primary way forward for afatinib initially. And this was a trial that took patients with a clinically defined acquired resistance. It started a number of years ago, so it wasn't demanded that patients all have documented EGFR mutations. It simply said they had to have been on erlotinib or gefitinib for at least 3 months. They had to have had some benefit from it, and when they came off, they were eligible for this trial. And this trial randomized patients to either afatinib or placebo. So there's no continued erlotinib here, there's no continued gefitinib. It's simply placebo or afatinib. The primary endpoint of the trial was overall survival, and as you see here, these are indistinguishable curves showing that there's no benefit in terms of overall survival. But the really big difference that was observed is this. If you compare the placebo to afatinib in progression-free survival, so adding afatinib really slowed the growth of the cancer as compared to placebo. I think the challenge here is trying to figure out if this is what you would do in clinic. So if you have a patient with EGFR mutant cancer who's developed acquired resistance, and do you just stop and walk away or not? And I think you probably wouldn't. You have a choice of other chemotherapy options. You have a choice of simply continuing erlotinib. But in the situation where you decide between placebo and afatinib, then afatinib is certainly better. And to really get that point forward, if you look at the overall survival in those patients in whom that decision was made in that dichotomous way, which is either nothing or afatinib, and then they don't get anything else ever again, then afatinib improves their overall survival. So I think my lesson from this LUX-Lung-1 is that continued EGFR inhibition is important, but it doesn't necessarily need to be afatinib. We still don't know. So is there an optimal EGFR TKI? This does show that there's evidence of effectiveness against clinical acquired resistance, but it's not the strongest evidence, and I think it's probably not enough to steer you away from using, say, conventional chemotherapy in that setting, and something that we can talk a little bit further about in the next session. So I'm going to briefly allude to these drugs now, and then we're going to we're going to talk about these more now because I think this is where we're going in the future. These are mutation-targeted EGFR inhibitors, and I put the title section from a paper in Nature a few years back. This is the first report of these mutant-selective EGFR tyrosine kinase inhibitors. The idea here is that when gefitinib and erlotinib were designed back in the 90s, they were targeted against wild-type EGFR. The goal was to hit wild-type EGFR, and it's because we didn't even know EGFR mutations existed. So that was the goal back then, and those drugs actually effectively do that. But since we now know that mutations are the key to sensitivity and that T790M is the key to acquired resistance, these drugs have been developed, a next generation of drugs, we'll call them third generation mutation-targeted EGFR inhibitors, have been developed to really get at those. And the promise is that they're going to be better in mutations and that they're going to have less wild-type EGFR activity and therefore fewer adverse events like rash and diarrhea than the first and second generation drugs. So the first one to kind of come onto the scene is from a company called Clovis, and this is CO 1686. This is a waterfall plot treating mice with acquired resistance to erlotinib, LA58R, and T790M. And you see on the left is the red bars were afatinib-treated mice, where there's clear evidence of some tumor growth, though a handful of animals had tumor shrinkage. And then on the right is CO 1686, showing that the vast majority of tumors shrank significantly. This is, of course, an artificial model, but it is a relatively faithful one, and this generated some excitement. And waterfalls in mice are cute, but what you want to see are waterfalls in people, and this is a waterfall from people that was recently presented at the World Lung Cancer Meeting. And this is a group of patients who have EGFR mutant cancer, who've had progression of disease after first-line chemotherapy with erlotinib or gefitinib, and then went on to this trial. All the patients were on EGFR TKI right up until going on to this trial. So the responses we see are not retreatment effects, they're real treatment of acquired resistance. All of these patients that you're seeing here had T790M. So this is part of the 60% of acquired resistance with EGFR T790M. And what you see here is that many of the patients have shrinkage. 8 of 9 patients had, or 67% resist response rate in evaluable T790M positive patients treated at the higher dose levels. This drug is still in phase 1. We still don't know the right dose. Toxicities are relatively mild so far. There's no significant rash, very little diarrhea. So this holds, I think, a lot of promise and something that we're all looking forward to seeing more of. But that's not the only drug. I'll tell you about one more, and there's still even more on the near horizon. This is a drug called AZD9291. It's being brought forth from AstraZeneca, and this is a different model. This is a xenograft model of that H1975 cell line. Xenografts are when you put a cell line into a mouse and it grows a tumor like on their leg or something like that. This is the activity of this drug in that model. And you see that in different doses, the dark blue at the top is 1 milligram per kilogram per day. The red is 5 milligrams per kilogram per day, and the light blue is the high dose. And you see that When mice are administered this drug, they have significant shrinkage, especially at the highest dose. And the optimist looks out at the far right, and where that corresponds to the gray bar, and you see that drug was stopped, but tumors didn't grow. So we may actually have potential to do better for these patients, where we're actually getting much more long-term benefit. So again, mice are cute, but what about people? This is people. So again, the drug is still in phase 1. The numbers you see on each of these bars represent the dose the patient got. And you see that many of these numbers, like 20 and 40 and 80, they're actually at, I believe it's 240 is the current dose that's being explored. But even at these very low doses, we're seeing partial responses in a large number of patients and significant tumor shrinkage in many of these patients. So clearly an active drug in this setting, and something that we look forward to learning more. Again, we haven't got the right dose. We don't know full evidence of safety, but it's definitely of interest. So in conclusion, erlotinib and afatinib have similar efficacy and similar adverse event profile, and I think they're relatively interchangeable in the first line and in acquired resistance. None of the currently approved EGFR TKIs adequately target clinical acquired resistance. And finally, third-generation EGFR TKIs that are mutation-specific have significant promise, and we certainly hope that these can make significant benefits for our patients going forward.